Hi, my name's Maggie Shearer, and in this presentation, I'm going to be talking about hemodynamics and circulatory shock. So let's go through some learning objectives. In this presentation, we're going to be talking about the differences between each type of shock, the four types of circulatory shock, signs and symptoms of each one, the diagnosis and different imaging techniques that are used to diagnose each shock, hemodynamic monitoring, pharmacologic options, ABG anomalies with each different type of shock, and the indications for mechanical ventilation. Let's start with defining what is shock. Shock is a life-threatening medical emergency where the circulatory system fails to deliver enough oxygen-rich blood to the tissues and organs, causing them to shut down. In this presentation, we're going to go over the four different types of circulatory shock. These include hypovolemic, cardiogenic, distributive, and obstructive. So, shock types are distinguished by specific physiological signs that reflect the underlying cause. For instance, with hypovolemic and cardiogenic shock, the patient will present with cold and clammy skin, whereas in distributive and obstructive shock, the patient will present with warm and flushed skin. To dive a little bit deeper into that, each shock will also have their own specific triggers that will help to differentiate them. So, with hypovolemic shock, that's caused by a low blood volume. Cardiogenic shock is caused by impaired cardiac output. Distributive shock is caused by severe peripheral vasodilation, and obstructive is caused by a mechanical obstruction. So, in my next four videos, we're going to dive deeper into each specific type of shock and explain them a little bit more in depth. Thank you. So, in this video, we're going to talk about hypovolemic shock. Hypovolemic shock is caused by severe loss of blood or bodily fluids, preventing the heart from pumping enough blood to the body. Some signs and symptoms include tachycardia, hypotension, cool and clammy skin, shallow breathing, confusion, and reduced urine output. Imaging studies used to diagnose hypovolemic shock are really going to focus on identifying the source of the volume loss itself and evaluate cardiovascular response. The most important imaging study used to diagnose hypovolemic shock is a contrast CT that's going to look for any active bleeding. We can see that in the picture below, the example of a regular CT and then compared to a patient in hypovolemic shock. And an ultrasound is going to look for any free fluid in the peritoneum or pericardium. An echocardiogram or an ECG is going to look at cardio function. And finally, an X-ray is going to look for any skeletal injuries or any air in the abdomen. Pharmacology management with hypovolemic shock is going to focus on restoring blood pressure and improving tissue perfusion. Fluids are extremely important in hypovolemic shock patients because, as we talked about before, hypovolemic shock is due to fluid or blood loss, so administering those fluids immediately is extremely important. Vasopressors, so that could be epinephrine, anything like that, are going to help support that blood pressure. And then finally, blood products or blood transfusions to restore blood loss. Hemodynamic monitoring is going to focus on identifying the cause of reduced preload, assessing fluid response, and restoring tissue perfusion. Patients in hypovolemic shock are going to present with a low central venous pressure, low pulmonary capillary wedge pressure, reduced cardiac output, and a low saturation of venous oxygen, and a high systemic vascular resistance. An ABG of a patient in hypovolemic shock is going to show a metabolic acidosis because of lactic acid buildup in the body. CO2 is also going to be low for respiratory compensation, and then the patient will be hypoxic, so that PaO2 is also going to be reduced. Mechanical ventilation indications, severe respiratory distress. Our patient's work of breathing is going to drastically increase, which will in turn increase our oxygen consumption, and intubation is just going to help support our patient with their work of breathing. Refractory hypoxemia, so despite any non-invasive measures taken to support our patient, they still cannot maintain an oxygen saturation greater than 90%. That's going to be one of our big indications for mechanical ventilation. An altered mental status is going to help us determine if our patient is able to support their own airway or not. And severe acidosis, so that's going to be a pH less than 7.25, and hypercapnia. So if that CO2 continues to rise, we will definitely want to administer mechanical ventilation. So some risks of mechanical ventilation in hypovolemic shock patients. First, hemodynamic collapse. This is going to be caused by the positive pressure ventilation causing an increase in those intrathoracic pressures. As we know, that causes a lot of extra pressure on the heart and mediastinum, which in turn reduces venous return and reduces cardiac output. In patients with already low blood volume, like our hypovolemic shock patients, this venous return and cardiac output reduction is going to be very drastic and very detrimental to our patients. Worsening hypotension is caused by the sedatives and paralytics used for intubation. Our patients are already presenting with hypotension, reduced blood pressure, as we said before. So it's very important to keep these patients on the lowest sedation possible. And finally, ventilator-induced lung injury. So really high pressure settings can cause barotrauma on the lungs. And finally, ventilator-associated pneumonia is also another risk of mechanical ventilation. So while mechanical ventilation is extremely important and can be very beneficial to our shock patients, it's also very important to keep the risks in mind and give our patients the best outcome possible. So that wraps up hypovolemic shock, and in my next video, we'll dive into distributive shock. Now let's talk about distributive shock. Distributive shock is caused by severe vasodilation resulting in low blood pressure, and it in turn restricts oxygen delivery to the tissues. Distributive shock is primarily driven by sepsis, but it also can be caused by anaphylaxis or neurogenic injury. Some signs and symptoms of distributive shock are warm skin, tachycardia, altered mental status, and decreased urine output and fever. Imaging studies used to diagnose distributive shock are going to focus on identifying the underlying cause. Bedside ultrasound is going to be the primary diagnostic tool used for rapid assessment. An ultrasound is going to help us evaluate the heart, look for any free fluid, and look at the lungs for any atelectasis or pneumothorax. A chest x-ray is also very, very beneficial. It's going to help us look for pulmonary edema, pneumonia, or pneumothorax as well. CT is going to help us look for any signs of infection. And an echocardiogram is going to look at the heart and help us to really identify distributive shock versus cardiogenic shock. So pharmacology management, norepinephrine or Levophed is going to be our first line of medication given. This is going to help increase vascular resistance. Vasopressin is going to help us increase that blood pressure. Phenylephrine is going to be used when the tachycardia is severe. Angiotensin II will be used in refractory cases. And finally, dobutamine and dopamine are going to be used for hypoperfusion or for myocardial dysfunction. So our hemodynamics in distributive shock are going to be a low blood pressure, low or normal pulmonary capillary wedge pressure, high cardiac output with low preload, which is a very dangerous place for the heart to be in because the low preload means that the heart is struggling to fill with enough blood, but the high cardiac output means that the heart is struggling to recover between each beat. This combination together can cause sudden cardiac arrhythmias, most often torsades, which is a very serious and very fatal form of BTAC, and a low systemic vascular resistance despite a high cardiac output. ABG anomalies. The most common ABG that you'll see in distributive shock patients is metabolic acidosis with respiratory compensation. So that CO2 is going to be really low. And sometimes it can present with a respiratory alkalosis due to tachypnea, and sometimes it can be mixed. Some mechanical ventilation indications are severe respiratory failure with refractory hypoxemia. This is very common in septic shock patients. An altered mental status will give us an idea if the patient is able to protect their own airway. Increased work of breathing is another indication to start mechanical ventilation, just to save the respiratory muscle fatigue. And refractory shock, meaning that the metabolic acidosis is worsening despite our pharmacology, therapy, and non invasive therapy.